it, and then talk about how it could be used for improving the accuracy and efficiency of assessing patients, of monitoring response to treatments, of supporting population health. But really, this is a brave new world. You have a new tool, I mean, you develop a balloon, well, what, and you can put it over a wire directed places. What might you use it for? There's a lot of potential application that we have yet to think about or anticipate, and it would be great to develop further sort of value and roles of understanding the patient experience in here and sharing that with others throughout the country. And then talk a little bit about early experiences with a focus on strategies to increasing its use and value in clinical practice. So why are all of a sudden a lot of people talking about PROs? Well, it really hasn't been that an acute thing, but it's gaining a lot of momentum. And as a backdrop, I think it's important to realize that the infrastructure for collecting and paying for the collection of standardized PROs has been longstanding. I think in 2002 or 4, they started developing Lloyd codes, which is sort of the EMR representation of the KCCQ and the SAC. Medicare reimburses this. I was actually surprised to learn this, but there's a CPT code. So every time you collect and score a PRO up to 4 per visit, the facility gets $2.91 from Medicare, and the physician can increase their E&M code. Now, I know we all put 5s anyway for every clinical visit, but theoretically, if you're taking, scoring, interpreting, and reflecting on the health status from formal PROs of your patient, you can go from 3 to 4, 2 to 3, or 4 to 5, and that would be justification for that. Commercial payers pay $12 to $16 for that CPT codes, and that's per sort of questionnaire administration. You can imagine how many patients we see in heart failure a year in the health system, and we probably aren't billing for it at all. But if we were, that's a non-trivial amount of money. The National Quality Forum was the first to really embrace the concept of the patient voice being very important. And I was on a committee representing the American Medical Association, and Bob Bono from the AHA and Joe Drossa from ACC and others, proposed PROs as part of the performance measures, and then they weren't supported by like the overall advisory faculty. Then the very senior group of the National Quality Forum said, "What are you guys talking about? This is the most important quality measure we have." So they got endorsed, and then when they came up for re-endorsement, Ray Gibbons thought that, look, we collect the CCS and the NYHA anyway, and he basically tanked it on the recertification about 5 years later. So it was endorsed, it was not endorsed, but the forum has now created a much more formal strategy and is encouraging the use of performance measures based on patient-reported outcomes. CMS has actually created a KCCQ measure. It happened just before Trump's first term, and Price sort of squashed it. It's still circulating, hasn't yet been implemented, but it's certainly part of MIPS already. For almost 5 years, the ACC and AHA have endorsed these as quality metrics, and the guidelines also allude to a class 2A recommendation using a formal PRO, but there have been a lot of clinical trials demonstrating it. The International Consortium of Health Outcomes Measurement does this. All of this is just trying to convey to you that, if external entities start requiring the reporting of PROs and you have to collect it as an unfunded, unnecessary addition to your work, it's a huge burden, very expensive. But if you can integrate it into routine clinical practice, so you're getting paid by Medicare or commercial for the collection of it, you're reporting it to CMS or the National Quality Forum as a byproduct of what you already do, that becomes a very low-cost, trivial burden on us, if any burden at all. And so the question is, can I convince you that it would be worth collecting the KCCQ, and how could you actually use it? And to do that, I really want to step back and talk about what it is. I mean, we talk about a lot. It's talked about as a clinical trial outcome in a lot of the structural interventions or cardiometabolic trials. But really, if you're going to use it clinically, you need a much deeper, much more visceral sense about what is it, what does it represent, what does a score mean, and so there is an underlying pathology that we call heart failure, right? So whether it's myocardial injury from multiple heart attacks, valvular disease, other types of LV dysfunction like HOCM, patients don't know, they don't feel their valve gradient. They don't feel their EF. What they feel are the symptoms of fatigue, shortness of breath, lower extremity edema, how it limits their physical and social activities, and how it impacts their quality of life. The discrepancy between how they're actually doing, feeling, and functioning, and how they would like to be. And I view really all of the ways in which the disease manifests itself to a patient, but not the underlying pathophysiology of the disease as patient's health status. And so there are, and you guys obviously know, for decades, we've been sort of leading the effort to develop ways of measuring patients' health status. And there's a myriad of psychometric properties. And fortunately, I'm going to bore you with none of it, except to sort of convince you that there's a lot of work that goes into developing these questionnaires so that we get valid, reliable, sensitive, reproducible results. And so the KCCQ was originally developed as a 23-item. We're really focusing entirely on the 12-item version today, but the asterisks are the domains that are not captured in the 12. But otherwise, what it's doing is it's capturing those concepts I just talked about, the physical limitations, the symptom frequency and severity, social limitations, quality of life. We can summarize these into into summary scores to sort of make them simpler to interpret. But really, the simplest thing to interpret is the overall summary score. And that's really what the bulk of this talk will be around. It's very important that and I will knock the New York Heart a couple of times during this presentation, but we usually feel like we collect a lot of this with the New York Heart, but this is different in that this is what comes from the patient's report. It's their perspective. It's not us interpreting how the patient's actually doing. There are about 120, almost 130 languages now. So this is available and used throughout the world. It's got very strong psychometric properties, which I won't bore you with. And the reason you're seeing it, sort of explode in the medical literature is because the FDA has qualified it as a clinical outcome assessment. So what that means is that if you develop a new drug or new device and it improves patients' KCCQ scores by a significant amount, it can be approved even without getting a trial that proves a reduction in death or hospitalization rates. And so this has been moving slowly, but it's part of why there's more and more and more use of the tool in clinical trials. So what is it? You keep talking about the KCCQ. I mean, I just thought it would be worthwhile. And this is the KCCQ 12. This is what your patients are filling out in clinic. This is it, right? It's 2 pages. There are 3 questions that ask, how limited are you because of your heart failure in showering, bathing? So this is 2 to 3 minutes of activity, walking a block on level ground, sort of 4, 5, 6 minutes, or hurrying or jogging as if to catch a bus, sort of 5, 7 minute activity. And it ranges from extremely limited, so you can barely do it, to not at all. And then because we want it to be disease specific, if somebody has a BKA, and so they can't walk on a level ground or hurry or jog as if to catch a bus, they would just say it was not limited. And the reason you want them to do that is that if you're trying to use this as a tool, for example, to monitor, are my heart failure treatments helping this patient as much as they could, and there's another reason why they can't do an activity, it will change regardless of how well you treat them. You want this to be very disease specific. And so that's why it was constructed this way. The symptom scale asks about how often patients have lower extremity edema, fatigue, shortness of breath, orthopnea. The quality of life scale asks just 2 questions about quality of life. How much it's limited their enjoyment of life. If they had to spend sort of the rest of their life this way, would they be satisfied or not at all? And then finally, difficulty in social activities, hobbies or recreational activities, working, visiting friends out of your home. These are the kinds of questions that you ask your patients with heart failure when they come in to understand how they're doing. Now, what's unique about this is that it asks these questions the same way every single time. And you on Monday morning, when you know your next 2 clinic patients have canceled, have a lot more time to really talk with your patients, to listen to their history. You're not tired. But Thursday afternoon, and you're Mikhail Kosovo, it's 7:30 at night, the staff are, yelling at you to go, and there's 5 patients waiting to be seen. You're a lot more rushed to taking your history, and you may not be doing it with, all right, Mikhail would take it the same regardless. But the rest of us, when we get, rushed, when we're tired, when, we're distracted, we don't take it the same way. This asks it the same way every single time. And the other thing I'll just note is that there's the worst items tend to be on the left, the right items tend to be, the best items, the best responses tend to be on the right, and we'll come back to that later. So, what's good about this instrument is that it was designed to exactly map to this underlying framework of how a disease impacts the patients. And you often will see the clinical summary score in drug trials because the FDA on the device side qualified all the domains, but the drug side only qualified the physical and symptom scale and the clinical summary score, but not the social limitation or quality of life scale. And therefore, they don't like the overall summary score, which captures sort of the totality of patient's health status. So, to me, if I'm, I've not worked in a clinic that actually had the KCCQ available, but the way I would approach it is I would start with the overall summary score. And for 99% of you, that's where it'll stop. That'll give you all the information you need. There are advantages of drilling down into subdomains. So, for example, and this is more true probably with coronary disease than heart failure by the nature of the disease. But, if somebody has a poor, a summary score of 60, and, you thought like, boy, they didn't have any symptoms or they don't seem to be limited to doing everything. Why is that? Well, you may want to delve in deeply. And in the case of coronary disease, if they have a physical limitation score of 100 and an angina frequency score of 100, meaning they have no physical limitations, no symptoms of angina over the past month, but they have a quality of life score of 50, well, maybe they're really depressed. I mean, there may be other ways of thinking about what's going on, or, and so there are value in digging deeper if you want to sort of figure it out. Or if somebody has a score, is it that they have a lot of symptoms and they're still doing a lot of activity, or they're not doing a lot of activity to minimize their symptoms? I mean, you can find out a lot of that, but 99% of the time, all you're going to really need is the overall summary score. And the overall summary score goes from 0 to 100. All the scales are transformed to 100. 0, as I showed you in the thing, represents somebody who's always tired and shortness of breath. They just feel that way all the time. It's extremely difficult even getting dressed, terrible quality of life. Whereas a score of 100 means they're never tired or short of breath. They have no physical limitations. They have excellent quality of life. So this is the range. And so I'm going to try and lay out for you different ways of understanding what a score means and what a change in score means. But ultimately, as we get to the implementation, from the early qualitative interviews of people who've used it, it's just using it. It's really just getting a feel, because you'll start to get a heuristic sense, an imprint of what a patient with a score of 40, 60, or 90 looks like. But if you haven't done that yet, you can think about, well, how does this compare to a New York Heart classification, right? Because we use the New York Heart, we all have a visceral sense of what an NYHA 1, 2, 3, or 4 represents. Well, it turns out that it's very hard to map to the New York Heart because it's very variably assigned. So I'm just going to focus on there it is. I'm just going to focus on this graph here. And, what we've looked at is the distribution. So what's the distribution of all the people who have class 1, 2, 3, or 4? These were outpatients with HEPRA. And what you see is that these are the baseline KCCQ scores on the x-axis. And this is the probability that a patient, for example, with class 1 would be, would have a score, of 190, 75, whatever. And so it just shows the variability and overlap. You can see all the overlap here from HF Action and from Tomcat. And, what it means is that if somebody has a score of 50, depending which doctor they saw, 5% of the patients who are called class 1 have a score of 50. 10% of the patients class 2 have a score of 50. 18% of the patients class 3 have a score of 50. 5% of those who are class 4 have a score of 50. I mean, it shows you how irreproducible the New York Heart is. And so it's hard to map the KCCQ to the New York Heart because you can't map something that isn't measured accurately. But, to me, I think heuristically that sort of a score of about 0 to 45 is class 4, 45 to 60 is class 3. I realize my arrows aren't quite right. Class 2 is 60 to 80, and greater than 80 is class 1. And there's some fuzz around it, but you're just trying to get a gestalt. A simpler framework, and the way I would do it is just look at ranges of scores. 25-point ranges. 0 to 24, you're doing very badly. I mean, and you saw the figure of that. A score of 25 to 50 is poor to fair, fair to good, good to excellent. And, this has a lot of prognostic significance. This was one of the first trials, the Ephesus trial, where we looked at the patients were enrolled in the hospital after an MI with heart failure. And this was the 3-month visit, I believe, that we looked at their scores, and then we looked at the rate of cardiovascular death and hospitalization. And what you see is over 2 years, about 20% of the patients with scores greater than 75 have died or been hospitalized. But of patients with scores of 0 to 25, over half have been hospitalized or died within 6 months. There are not many things that we do that can risk stratify so dramatically, right? And so this is another way of understanding, just looking at simple ranges, how sick the patient is you're looking at. Interpreting changes in scores, how do you figure out what magnitude of change on this 100-point scale is clinically important? This turns out to be one of the biggest arguments going on in our field right now. And there was an interesting article that the FDA put out against what we'll call responder analyses. We're in the midst of revising and resubmitting a counterpoint to that. But our understanding of what's important stems from one of the first studies. It was the study that founded the Cardiovascular Outcomes Research Consortium, a network with Yale and Harvard and Duke and Colorado that we helped develop here back in 2000. And the issue is that Searle, which has long been acquired by multiple gobbly entities, was designing the Ephesus trial, and they were using the KCCQ, and they were concerned there would be like a 8-point difference between arms. And the FDA said, well, it's statistically significant. You had 2,000 patients in it, but is it clinically important? So they supported an investigator-initiated study to figure out what's a clinically important difference. And so we basically took 546 patients recruited from 14 North American centers, sort of our friends and family at the time, of whom almost 500 had a 6-week follow-up. And so we picked, basically the idea that we would collect a KCCQ and we would collect it again 1 to 2 months later, which is about 3 times the recall period, and look at how much, if a patient said they changed a little bit, a moderate amount, or a whole lot compared to a month and a half earlier, what was the average change in the KCCQ score? So essentially, you're exploiting the random variation of health status of patients with heart failure, which is clearly present. And this is what we found. I mean, this is still one of the most amazing slides that I've ever been involved in producing. And what it shows is the average difference in KCCQ scores from the average change in KCCQ scores for patients who were stable or who got a little bit, quite a lot, about a huge amount better or worse. And what you see is tremendous symmetry, and that basically a small but clinically important improvement is about 5 points, same for deterioration. 10 points is a moderate one, and 15 or 20, there aren't a lot of patients in those groups. We picked 20. A lot of people have been going to 15, which I think is totally fine, but 20 represents a large improvement. And there have been lots of correlational studies. Like, you guys aren't getting much of a sense of what small, moderate, large means. So this was some work that was done from a couple of different studies. The HF Action study tried to correlate it with a 6-minute walk and B.02, but a 5-point change in HF Action was about 112-meter difference in 6-minute walk, which is a huge difference. I mean, in other populations, a 10-meter difference in 6-minute walk is considered large, so considered important. A 2.5 mil per kg per minute difference in ventilatory capacity, huge difference, 5 points. There is about a 10% change in hazard ratio for mortality and hospitalization if your score goes up or down by 5 points. And, to give you a visual sense, what does that mean? Now, it's even more dramatic on the 23, but you're going to use the 12. So this is the 12 item thing. So, if this is how a patient responds on the KCCQ, and you see them 2 months later, and they go from having fatigue 3 or more times per week, but not every day, to once or twice a week. That's a pretty small difference. It's in the right direction, but that's pretty small. That adds only 4 points to just the symptom scale, but only 1 point to the overall summary scale, right? So just moving from multiple times a week to once or twice a week, that's 1 point on the KCCQ overall summary score, all other things being the same. If they also have their shortness of breath go from multiple times a week to less than 1 week. I mean, if I saw somebody and the last time I saw them, they were having fatigue, almost every day, now it's only once or twice a week, and they went from being short of breath almost every day to less than once a week, I'd say they were better. It's a small better, but they're better. And that's what a 5-point difference means. So it's a pretty, when you try and translate it, would you think this patient was better? I would. I mean, and usually there's different combinations that lead to that. And what is it compared against? It's compared against the New York Heart. So how good is the New York Heart versus the KCCQ at detecting change? So this is from the CHAP HF study, and it's looking at the change in this population in New York Heart and in KCCQ over 1 year. And what you see is that very few patients, New York Heart changes, 2/3 of the patient did not change over a year. But for the KCCQ, there's a lot of people who got worse, and only about a quarter of the patients really stayed the same, and a lot of patients got better. That increased sensitivity is really valuable when you're trying to monitor a patient over time. You want to know, are they getting better, are they getting worse? And when we looked at what best predicted in adjusted or unadjusted analysis, death and hospitalization, the New York Heart, change in New York Heart had no association, but the KCCQ did have an association where the higher your score, the more your score improved, the lower your risk for death and the combined death and hospitalization. So that's sort of what the KCCQ is and how to sort of think about interpreting it. Now, how can it be actually used in clinical care? And I think improving the accuracy and efficiency of medical history taking is really important. And you have seen this slide a couple of years ago, one of my grant rounds, but I really love it because when I was in medical school, I went to San Francisco, and at the VA, the vets had all kinds of different valvular pathologies and stuff. And as a medical student, you would go around with this senior gray-haired cardiologist because who knew what was actually the anatomy and physiology was? It was the guy with the greatest hair. They were all guys back then. Sorry, ladies. But what happened is, he would literally, teach us to feel the PMI, to percuss the heart, to, listen, to roll the patient, whatever. And he would describe, this is AI with here a little bit of an Austin Flint murmur, it's moderate to severe, blah, blah, blah. Here's how the duration. It was like Alan Forker, for those who remember the Alan Forker days. And, what this did is it led to a lot of variability in the accuracy and the reproducibility of understanding the anatomy and physiology of the heart. And then we evolved to the echo. And now docs can say whatever they want about what they hear and they don't hear. We want to see what the echo shows. It increases the accuracy and the reproducibility of assessing the anatomy and physiology of the heart. Well, who defines what the patient's symptoms and function is? It's the doctor using a CCS or a New York heart to interpret what the patient told them, right? And that also has a lot of limitations in accuracy and reproducibility. And I'm going to argue will be not replaced by, but supported by these kinds of tools. Now, this is the only time I'm going to shift from the KCCQ to the SAC because we just don't have data this good for the KCCQ, but I'm trusting one of our new fellows will figure this out and come up with a good study to do this. But, what is the purpose of the prompt, right? It's trying to get the physician to hear the patient's voice, right? And that's hard for us to do. And, now you guys have to know who this is, right? So Suzanne and I, when she was a fellow, we were working on a very interesting study called the APPEAR study. And it basically was replicating work that John Beltrabi, by the way, is going to be here after the ACC from Australia to give grand rounds on microvascular disease and all of that. And he's fantastic. He'll be here for a couple of days. So I hope we really take advantage of his presence. But he did a very interesting study that I won't go into that we tried to replicate here. I just don't want to take credit for his work. And so the theory was that we identified 24 practices around the country, and we asked them to enroll the next 25 patients who showed up and with coronary artery disease to compare patient and clinician reported angina. So, patients have angina and they describe to their docs, what they're experiencing. And we could understand from the patient how much angina they had by giving him a Seattle Angina questionnaire. Then the providers are listening to the patient, they make an assessment, and rather than rely on the CCS class, we actually ask them, did this patient have daily, weekly, monthly, or no angina? And with those data, we can compare it. And it turns out, as would be in our clinic, 2/3 of the patients were asymptomatic. And about 8% had weekly, daily angina, and a quarter had monthly angina. And when you looked at the patients with daily or weekly angina, the docs got it right 2/3 of the time. So 2/3 of the time, they said this patient had daily, weekly angina. However, a quarter of the time, the doctor said this patient has no angina at all. And, the overall concordance was a kappa 6.48, which is very bad. So what we thought is, well, why would we underrecognize angina, right? So we were pretty convinced that it would be underrecognized in women, it would be underrecognized in old people, it would be underrecognized in Black people. These were our hypotheses. And it turned out that when you look at all of the predictors of underrecognition, none of them are really impressive. None of them are significant, except for the median odds ratio. And what the median odds ratio represents is if I had the exact statistically identical patient going to one random clinic versus another, what's the likelihood that I would be underrecognized in one versus the other? And it's 2.5-fold greater. I mean, that's huge. And this is the raw data, right? So among the, whatever that is, 15 docs who saw more than 10 patients in the study, one doc, Dr. Arnold, never underrecognized patients' angina. She got it accurate all the time. Another doc, not Dr. Chatrawala, but somebody underrecognized it 85% of the time. They underrecognized their patient's angina. And I'm throwing names out. We have no idea who any of these people are. And it was Eric Grath who said, oh, I'm sure it's an interventionalist who's number 15, because once we've done a good angioplasty, we put in a good stent, we know that it's not really angina that they're complaining of. Regardless, the truth is that we all know this to be true. Some of us take a good history, some don't. Sometimes I take a good history and sometimes I don't. I mean, this is reality, but we just ignore it, right? But that doesn't happen with using a PRO, because again, it's getting the score the same way every time. And there are consequences to underrecognizing angina. I mean, we looked at what is the predictor of not escalating anti-anginal treatment, meaning adding an anti-anginal, referring for a cath, or doing another diagnostic workup like a stress test. And obviously, if you underrecognize their angina, you are 90% less likely to do anything to improve their angina control, which just makes common sense, So there are consequences for this. And when you have the scores available, you can do better. So Alex Sandu did a K award on implementing the KCCQ, and we'll come back to some of his work. But with the baseline data, what they were able to do is they randomized 500 patients, 450 patients into two arms. All of them got a KCCQ at the beginning of the study, and at the end of the study, 12 months later. Half of the patients, the KCCQ was put into Epic and available to the doc and the patient to do not only at baseline, but in every visit. And the other arm was standard care. It was not put into EMR and not available. And so, the question was, if the doc could access the KCCQ at baseline, would they be more accurate in assigning the New York heart than if they didn't have the KCCQ? And so I showed you those curves before. These are the curves for stratified by New York heart class, and we're just going to focus on number 3. So this is the distribution of the KCCQ scores in the patients whose doc said they were class 3. And what you can see here is that in the dashed line, these are the patients whose KCCQ scores were not shared with the doctors. And it's a lot broader distribution, with class 3 being assigned to a lot of patients with KCCQ scores in the 80s and 90s, versus when the docs had access to the KCCQ score, it was a much narrower distribution in the range where we sort of think about being New York heart class 3. So it says to me that not only can we sort of reproducibly capture patient symptoms, function, quality of life over time, but that when the docs have access to this, you're getting a more similar rating of New York heart class 3 across different doctors who are seeing the same patient. Now, monitoring response to treatment, to me, there are several different examples I want to give. And the first is an opportunity to improve care that is literally been at our, beck and call for a decade. And Chetan Udan is the one who I really want to credit with this idea. And the idea is that in TVT, you're sort of mandated to collect a baseline 30-day and 1-year KCCQ. And, the KCCQ at 30 days after the procedure is a very strong sort of predictor of prognosis. You know, the use of the 1 year, 30-day or 1 year sort of KCCQ combined with survival creates an alive and well quality measure that PDT uses. And so we're collecting it in care and we never look at it. Like the doctors never look at it. Maybe we look at it here a little bit more because I've pestered so much, but in reality, you know, most places the nurse practitioner gets it, goes to the NCR, it's never been looked at. And, you know, it has a lot of information. This is something that, you know, Vital led, where he was sort of looking at the prognostic significance of the baseline and the 30-day and the change in baseline to 30-day KCCQ in predicting either death or hospitalizations. And, you know, sure enough, the baseline and the 30-day, the higher the score, the lower the likelihood of dying or being hospitalized. But when you included them all in the model, basically it's the follow-up KCCQ that carries most of the prognostic significance. So when you see somebody in clinic after a TAVR or after a MitraClip, and you look at their KCCQ score, that score today, regardless of how much they improve, is going to be very strongly prognostic. And so, you know, what you can imagine doing is, you know, thinking about how to leverage different aspects of a healthcare team to do it. So the valve team is very focused on the success of the procedure. But, you know, while patients can benefit from treatment, they may benefit from also treating their underlying heart failure. So somebody who starts with a KCCQ of 40 and they go to 60, well, they got a big benefit from their TAVR, but they still have a KCCQ of 60. Like, maybe they need an SGLT2 inhibitor. You know, maybe they're fat and need a GLP-1 for their HFpEF. You know, whatever it is, they could probably benefit from additional therapy. And so, you know, Chaitin created this algorithm that if the 30-day KCCQ score was greater than 75, fabulous. So that's the high range. If it's less than 75, you can get more thoughtful about things, try to triage between, you know, structural things you have to worry about versus not. But simplistically, from my viewpoint, if it's above 75, you let usual care happen. If it's below 75, you refer them to heart failure to think about, or a heart failure nurse practitioner to think about other strategies that could be employed to get their score from 60 to 100, because that's your ultimate goal. And it makes our procedures look better. And there's a whole myriad of things that could be thought about to help do that. When they show up in that nurse practitioner clinic, when they show up in heart failure clinic, you also could leverage the KCCQ. So, you know, we have a lot of new treatments for heart failure, and they all sort of have a 20% relative, 15 to 20% relative risk reduction for death and hospitalization. Why not choose therapies based on their quality of life? In fact, you could sort of test individual patient, therapies in individual patients by giving them the KCCQ before and after treatment and seeing if they get better. If they get better, you continue it. And the patient knows why they're taking that medicine. Oh, I'm taking this medicine because it improves my symptoms, function, and quality of life. And if it doesn't, maybe you try something else. So graphically, you basically see a patient clinic, you get their KCCQ, you do whatever you're going to do to intensify therapy. They follow up with another KCCQ. And if it's greater than 5 points better, fabulous. If it's not, maybe there's other benefits of the therapy, or maybe you want to try something else. And so it just gives a sort of simplistic, reproducible clinical way of thinking about incorporating this. And, you know, I neglected to say, I'm sorry I did mention this point, but, you know, when I show this slide here about when I showed this slide about slight physician variability, it sounds like I'm blaming the doctor. And I neglected to bring out a really important point. And so some of you will remember Charlie Porter. Charlie Porter was a heart failure doc here and worked with Dennis Preston. work with this. Oh, God, man. Just get so choked up remembering the old days. A bunch of us worked on developing the KCCQ, and so Charlie was really enamored with this. And so, I mean, he in 1998 he was using it in clinical practice, and so they had these scantrons, these bubble cards that people filled out, and you would shade it in, and then there was some sort of thing that stuck. So you would put in your responses to the KCCQ on that bubble card, and then he would have to go to a scan, try to get scored. But he would look at that card, and when he walked in to see the patient, and he would look at the card, and if I remember I went through the things. A shift to the left means they're doing poorly, right? Because their scores are sort of on the left side. And so he goes in to see this patient. She's got a huge shift to the left. He says, "Hi, Ms. Schultz, how you doing?" "Oh, I'm doing great, Dr. Porter." "Oh, really? Any shortness breath?" Oh, no, Dr. Porter. Difficulty climbing stairs?" "No, I'm doing fine, thank you." Well, I'm just curious. Before you came in here, you filled out this questionnaire and you sort of said you were having shortness of breath all the time. He goes, "Well, yeah, I guess I am." "And then it was hard for you to climb a flight of stairs?" "Yeah, I've been really waiting for the elevator if I get out at all." "Well, I just asked you that. Why did you tell me you were doing so well?" "Oh, you're such a good doctor, Dr. Porter. I didn't want you to feel bad." So there are lots of reasons why we have difficulty getting the history, but nobody feels bad about putting how they feel on a questionnaire in general. And so, that becomes very, very important when you're thinking about sort of, monitoring response to therapy, because they may tell you what they want you to believe, not, what they really have experienced or felt. Um, you know, we don't do much population health here. And I presented this a few years ago, but I thought the most extraordinary way I've ever seen this system change was what happened during the COVID pandemic, right? And our use of telehealth. And so one of the fellows wrote this up, and it's this Mahi experience of telehealth, where essentially we did 0 telehealth visits until the shutdown, where we very rapidly shifted 85+% of our visits to telehealth. And as soon as they ended the shutdown, we went right back, and now we're doing about 98, 99% in-person visits. And does that make any sense, right? I mean, think about it from what's most efficient for us, what's most economical for the payers, and what's best for the patient, who will have to drive in, find a parking spot, spend all day waiting, just to get their medicines reviewed. What if, you got a KCCQ before, 3 days before their visit, and if, they were no worse, that means that the change in their KCCQ was, greater than -5 points, so stable or improved, just do a telehealth visit. But if they're worse, then you bring them in for in-person visit. If we think about sort of Medicare Advantage, if we were really at risk for our patients, we would be absolutely doing a lot more telehealth. We don't do telehealth now just because of sort of the idiosyncratic way healthcare is reimbursed. And so I think, again, I'm just trying to, challenge you to think about creative ways we could do it. Pop health management, this was not a study done for this, but in that CHAP registry of 5,000 patients, we sort of looked at the distribution of patients in clinics who had what proportion of your clinic patients had a KC score greater than 75. And essentially, this is what we saw. Now this could be operating, just happens to be clinics and lots of different clinics, and there's a lot of variability here that I don't want to go into, but the idea that you could survey a population, find out who's doing poorly, and if they haven't seen a heart failure doc or even a cardiologist in the last year, bring them in proactively if you want to help sort of manage that population well, especially given all the changes in treatment that have happened. So what are the early experiences of actually using it? So in Utah, they rolled it out in their heart failure clinic, and of 24 patients who underwent deep qualitative interviews trying to understand what the patient experience was, 23 strongly felt that it gave the providers a better sense of their heart failure. And 2/3 thought it was really helpful in doctor-patient communication. And, 22% felt it improved the care. When we care so much about our HCAP scores for our Vizient, judging of how good a quality system we are, or what Medicare will say, or how we'll get reimbursed from Medicare Advantage, these patients felt they got a lot better care and that the doctor understood them a lot better just because the KCCQ was being used in the clinic. And in fact, 2/3 of them felt more time should have been spent discussing the KCCQ, such that, from the patient's perspective, they really like these PROs, but really only if the doctor's going to talk with them about it. From the doctor's perspective, and this comes from Alex's effort at Stanford, they thought that it was really helpful to get this launched with an engaged clinical champion. I think Tim and Sanjay have led the charge here. I haven't been very involved, but hopefully they've been super engaged, super helpful. This is a lecture along the lines to give you some of the background to use it. Experience is key, and I alluded to this before, but the more you use it, and this is one of the docs at Stanford, the more you use it, the more you get a visceral, heuristic understanding of what these scores mean. And so that's really important. That's really valuable. And, I think getting it integrated into workflow, and I'll touch on it a little bit here, but I think that Sanjay's done a phenomenal job getting it integrated where you guys want it in the Epic portal. Providers, this is how, that was sort of the implementation side on how it helped them deliver better care. It was standardized history taking, like I talked about, better patient communication. The doctor felt that, he was able to understand from their perspective how they were doing, and Tim Pedler tells a story of walking into a room with a patient with a score of 20 on the KCCQ, and stoic farmer, how you doing? And she says, great. Any change? No, not whatsoever. Looks at the wife, how's he doing? He says he hasn't left the couch in a month. People sometimes don't communicate well, and this gives you a common ground to probe when you're not getting perhaps the most accurate answer up front. And then other doctors really like, you see that right now your KCCQ score is here. I think if we start this medicine or we get you this procedure, we can get it up to there. And the patient all of a sudden has a much better understanding about why they're doing it, getting offered a treatment or being referred for a procedure, and are going to likely be much more confident because they understand it. Again, more people really like the accuracy of the history because everybody does it differently. This more complete picture of the patient's perspective, their disease, and the ability to track patients over time. Sadly, when Alex did this study that I alluded to before, now this is an unusual the Stanford clinic's a little unusual. A lot of people, so their baseline KCCQ was like 82 or something, which is really high for outpatient with heart failure. It turns out a bunch of these patients were patients who had genetic risk factors for inherited cardiomyopathies, but didn't really have heart failure. There are complex subtleties here, but ultimately, when he looked at the difference, the baseline mean score was like 82 in both groups. It was about the same a year later, and there was really, no difference between the arms. However, some of the docs really used it and some didn't. And so they did a separate survey, which really matched with their qualitative gestalt and divided the docs who never looked at it. Because if it's in the Epic and you never look at it, how could it help? Versus the docs who used it and talked with their patients about it. And what they found was, even in a small study, a statistically significant interaction with almost a 5-point difference in the change over 1 year, where would it be much better than the docs who actually used it, which makes sense. You can't use it if you don't, you can't help if you don't use it. So in our system, we have, it's in the snapshot in chart review on the cardiology summary page. I have no idea what that means, but, because I use Cerner, not Epic, but apparently you can click on your list and find this very rapidly. You can put it in your note with the dot phrase dot KCCQ12 score. I think there were almost 1,600 of these done in the last quarter. And I think it's something that hopefully you'll view this as being very beneficial, making you more efficient, helping you work with your patient, et cetera, and that it will continue to go. And so, I just sort of ultimately feel that I can talk all I want, but until you actually try it, you won't really have a good sense of it. And so I'd love to answer any questions you have, and I really appreciate the opportunity to present.
So our perspective from the valve clinic is that, so we don't have a snapshot or the tab or whatever, it's in our notes. It's right above the plan, so I have to go to the top of the note to dictate my HPI. I have to go to the bottom of the note to dictate my plan. Right in between the diagnoses and the plan is the KCCQ and the serial ones, from different dates. So I see it every time in the valve without having to, go find it. And, I agree with all the stuff. It's helpful. We have patients who, they can't remember what they did yesterday, much less, how they felt before their procedure versus now. They have a very hard time, voicing that. And, so we can look at that and see how people have improved or not. And it's also helpful at the baseline, when we're trying to figure out if patients are symptomatic enough to warrant a procedure, especially when it's surgery is the procedure, and it's not just TAVR, but it's going to be invasive surgery. So even, like Keith Allen is, very focused on the KCCQ, to try to decide, whether somebody needs something. So I really don't see any reason not to just automate that into our notes, and you'll have people looking at it. And, and like you said, the more you see it, the more familiarity you'll have, and the more you'll know, kind of what to do with it.
You're just from a gestalt. Do you feel like it's doing is it helpful to you like this? Do you feel it does a pretty good job representing what you sort of understood patients to do, or where there's a discrepancy? Is it, I'm just curious, just visually, do you look at it because it's helpful, or you look at it because,
Well, no. And so, to be clear, so this project that, is looking at KCCQs less than 75 and getting them involved in the heart failure team, that's only just very newly starting. The KCCQs have been on our notes for, a year plus or something like that. And we have found it beneficial. Absolutely. And I agree with the, the variability. It's kind of amazing, honestly, that we follow patients who are in clinical trials, and we have these arbitrary NYHA classes. It's actually going into a clinical trial, and you've got, 15 people who would, classify it differently. It's amazing, actually.
I just want to say, I thank you, Dr. Spertus. This is a wonderful presentation today. And I actually worked in a clinic where we used this for several years and assessed our heart failure patients every 3 months with the KCCQ. And exactly what you said today. I will echo what you've just said. And it was very valuable, not only to us as clinicians to risk stratify patients, did they need to be seen more frequently, but the patients loved it, and they loved the conversation that you had. And if you didn't mention what their score was, they often asked. And we had the capability of being able to graph what their score had been over the last year or two. And you could see as we made therapy changes in medications and or other, device therapies, where they really could see, and they truly became believers. And it really helped you because patients did not always tell you the truth about their symptoms. And so you would see a change and you'd go in and really dig a little deeper and maybe prevent that next hospitalization because you were able to make some changes or follow them more closely. So thank you.
It is so validating to hear that, because, most people, very few clinics are actually using it. And those who have used it, started with you can't sell somebody a solution to somebody who doesn't feel they have a problem. And most doctors do not feel like they have a problem getting a history, like that's their job, right? And it's only by actually using it and getting a sense of it that you even become aware that this potential to make things, easier, more efficient exists. And so it's, how you get people to sort of try it. It sounds in both of your experience, like once you started using it, you start realizing, oh yeah, this really is helpful. Like I never would have thought I had a problem doing this stuff, but this makes my job easier. The patients like it. It's a good thing. That's really exciting to hear. Okay.
Fabulous. It's amazing how it took us so long to kind of slowly embrace this here when you're here.
You're the one to thank because you're the one who finally got it over the finish line.
All right, so let me ask you something. So when patients have 2 or 3 competing illnesses, so let's assume they have heart failure and you have pushed the GDMT and you're thinking you have given them stuff that we know will reduce mortality, hospitalization, and they have a component of COPD, they maybe have a component of maybe depression or arthritis, and you're here to try and tease out why they're still not feeling well. And I'm just wondering, you make this, I mean, this is easy if you have just kind of one problem, like just TAVR, as Adnan just says, take care of, just heart failure is a heart failure. But, the rest of us people who kind of see the general blend of cardiology patients, they come in with a myriad of kind of symptoms and overlapping kind of problems. And we know we'll make them better with GDMT, but they may still say, I don't feel well. And so is it because we have still under-recognized the severity of their heart failure, or have we, it's not our gig to kind of take care of their exacerbating COPD, their arthritis, their depression, and they still have a score of 55?
Well, I think that this is to help you try and tease that apart, right? Right now, you're teasing that apart without a very sensitive measure of how much their heart failure is improving.
I got an echo. I'm good.
But
I have an echo. I'm good.
but the point is that it's like if there's overlap between the symptoms of heart failure and COPD, and if you've optimized their medicines and and a lot of our medicines have marginal effects on health status, to be truthful. ACE inhibitors and beta blockers don't necessarily have a huge improvement in health status like the GLP-1s do in obese HFpEF, but nevertheless, you may find out that, altering their COPD regimen leads to a huge improvement. And so
GMT has a modest effect on quality of life, KCCQ changes,
well, different components of it have different effects.
but it's modest.
I'm sorry.
It's modest, you say.
I mean, in the randomized trials, it's modest. The difference in the proportion of patients get a whole lot better from the first TAVR trials versus any of the GAPA trials. It's just, it's in that context. It's not that they don't help, they do get better. And, Mohammed just wrote a good paper in JAMA Cardiology about looking at the distribution of individual patient scores. So even though the B differences can be small, you can still have low NNTs for one patient to feel a lot better. And that's a different sort of health status talk. But what this does is it gives you a better measurement to see how treating their depression or treating their COPD or treating their heart failure is altering their overall health status. And so, you still have to figure out as a clinician what you need to do. And it's complicated with complicated patients, but this gives you a better, I think, more refined measurement tool to understand the heart failure component and whether it's really needs more heart failure treatment or can be considered for CRT or something like that, or whether or not you ought the pulmonologist to do a better job.
So my question is more St. Luke's implementation of the KCCQ, so maybe Adnan or other people who do clinic can answer this. If you see a patient with a KCCQ score, can you actually bring up the questionnaire, the actual responses? Because with David's point, if somebody has comorbid COPD and morbid obesity, maybe the actual responses to the questions can provide insights. If it's swelling versus shortness of breath, that's driving a KCCQ score of 60. So I'm just wondering if there's any way to pull in from EPIC the actual report.
I don't know. I've never tried to do that. I imagine that they might be scanned in media, but I don't know that.
No, I don't think it's that. I think it's
There's a flow sheet in Epic.
Yeah.
You can look up the individual response. I can share. No way.
I think you can. I know it generates already all the summary scores, but if you want to look at individual items, it's part of a flow sheet because that's.
So, you know, if I'm planning to see a patient, it'd be nice to know what it actually they said about shortness of breath and edema, so I can enter in directly into a conversation, straight into, you know, I see you responded, you're having shortness of breath every day. Tell me, what, you know.
I mean, do you ever look at the review of systems that the MA, you know?
Yeah.
It's like the MA says they have chest pain, you go in there and they, you know, you have chest pain and they say no. It's crazy.
Are we doing this for just half?
Oh. These all.
Right.
HCM.
Question. I think this is great and I think it's incredible that, you know, this tool has now determined if a drug or a device gets approved by FDA. But specifically for device trials, you know, specifically like I'm thinking about tributyl, if there's not a sham control, you know, arm, do you have an idea of how long like placebo effect may affect your cases?
I'll begin the experts. We have two experts here, one on drugs, one on device. You asked about devices, so
Yeah.
they'll start.
We,
and then-
we did a device, so we did an analysis of the sham controlled device trial, trying to estimate placebo effects where there was a blinding period and then an unblinding period, and patients were unblinded. We estimated the placebo effect as the decrement in the KCCQ going from blinding to unblinding. And we found that the estimated placebo effect was small. It was only about 1 point relative to the overall change in KCCQ from baseline to the end of the blinded period, which was about 8 or 9 points. And so in the control arm, that represented the placebo effect for the control arm. But for the intervention arm, we viewed it as the placebo benefit, which was the change in KCCQ from blinded to unblinded period, which was also very small. So that would be the placebo effect in an unblinded trial effectively.
And I think, you know, it turns out there's a lot of reasons people could get better in a clinical trial. I mean, part of it is the treatment. Part of it is the placebo effect if they're randomized to placebo. Part of it is that there's just regression to the mean. They were enrolled in the trial where they were doing poorly and so naturally be getting better. You know, they could find, you know, because they're showing up to these visits for clinic visits, they're finally actually taking their medicines like they're supposed to be. Maybe they're getting better educated on their disease so they understand why they're taking their medicines. I mean, there's a myriad of things. And so when you have a single arm trial like Triluminate, it's hard to know what proportion of that benefit is all these other trial benefits, regression to mean, et cetera, because you have no comparator arm well, actually, Triluminate had a medical arm, but they did just the medical arm knew they weren't getting treated. So that's really probably a very small part is the placebo effect, and the medical arm may have got better. And you just need to make sure that they're treating the patients in both arms equally well. But my general gestalt is that there is some placebo effect. It's a lot smaller than most people pretend. And again, I'll go back to the effect size in the ischemia trial, the Seattle Management Questionnaire, which is an open label study, was exactly the same as the effect size in the sham controlled Orbita trial. It just wasn't statistically significant in Orbita because it was 200 patients instead of 5,000. But my view is the placebo effect on these questionnaires are fairly small, in large part because we're asking very concrete questions. I mean, I showed you the questions. It's not like compared with when you started, how much better do you feel you are today than before? That would be subject to a lot of placebo effect. But you say over the last 2 weeks, how often have you been having shortness of breath or fatigue? I mean, that's pretty concrete. And so I don't think it's as susceptible to a placebo effect as most people would think PROs to be, but there's something, and a sham control is always better. But when you can't do a sham control of PCI versus CABG, right? I mean, how do you do a sternotomy and not do the bypass? Like, you know, there are things, sometimes we just can't do it. And I don't think I would throw out the PRO outcomes on that basis. Well, thank you guys so much. I know I've cut into some of your workday, but it's great to have a chance and I hope it's helpful. And I'd really like to hear feedback on whether there are ways that this could be more helpful because other centers are starting to roll it out. And you know, things we've learned here that we could share with other centers would be great to share. So thanks.
Thank you. John.